Overcoming Cancer and Conversations. Have I got the book for you? Hey there, I'm Dr. Jordan Soper. I'm a board-certified behavioral and cognitive psychologist, as well as an ASEX-certified sex therapist. And I have the new book by Katz, Cancer, Sex, and Intimacy, where she talks all about how cancer impacts sex and intimacy with persons, individually, and within couples. The book talks a lot about different case examples, actual humans' experiences going through this entire journey, how it impacts the individual, the body, the couple. It really talks about different evidence-based ways to address and treat this really, really common issue. And I actually wanted to read one of my favorite chapters out of the book. Yes, I've read this book twice. It's talking about what happens during the end of life process. I know this is a scary topic for many individuals, but this is one I feel really passionate about. Shocking, I want to talk about death as a goth psychologist. Who would have thunk it? But we're going to actually read a little bit of the chapter. Now, I wanted to give you a little heads up about what's going to be happening in this book. The thing I love about this book is it has actual case examples in it, but I'm not going to read those examples. I want you to do that on your own. What I am going to read is the information that is included in this particular chapter. So you're going to notice I'm bouncing around a lot today, but I promise there is a reason. So let's talk a little bit about intimacy, cancer, and death. I know, fun topic, huh? Come on. Chapter 10. I miss touching her. Sexuality at the end of life. The need for touch doesn't go away at the end of life. In fact, touch may even be more treasured when time left is finite. People at or near the end of life are often regarded as untouchable, and partners may feel the need to receive permission to touch their loved one. Sexuality at the end of life is challenging. Couples may be reluctant to initiate any kind of touch that may be misconstrued as sexual initiation rather than touch for connection or comfort. Healthcare providers may also, unfortunately, not even consider that touch remains a need at this stage of the illness. Hospice care refers to the special services that people with terminal illness can access if their life expectancy is 6 months or shorter. Services include pain and symptom control and access to equipment such as a hospital bed, oxygen, and other resources, but there's no active treatment such as chemotherapy. People who choose hospice care experience fewer visits to emergency departments, as well as increased satisfaction and better end-of-life care. The sexual needs of the person at or close to the end of their life and their partner aren't always discussed with the palliative care team. Despite these needs being seen as a fundamental part of palliative care and included in clinical practice guidelines for palliative care professionals, this omission in care is related to incorrect assumptions both the healthcare providers and patients or partners' discomfort with the topic, and a lack of education for healthcare providers on the importance of sexual needs at or near the end of life. Sexual needs doesn't necessarily mean intercourse, which may not be possible or desirable because of many physical factors, but rather the term can encompass non-genital touch and verbal communication. When someone has advanced cancer and is facing the terminal phase of the illness, the partner often becomes involved in their technical care, and their role changes from that of an intimate and sexual partner to that of a caregiver. The partner may be afraid of causing pain with their physical touch or discomfort from the medical devices that might be supporting the person with cancer. Palliative care refers to pain and symptom management and providing comfort and improving quality of life for both cancer survivors and their family caregivers. It's not dependent on the stage of illness and it can be offered while someone continues to receive treatment for their disease. While many people would rather die at home than in hospital, it's not always easy for family members to facilitate this. The family or other caregivers need to be supported practically, help with meals, laundry, etc. Mentally, managing medication schedules safely, and emotionally, knowing what to expect in the final days and hours. For family members, the benefits of having the dying loved one at home includes a sense of purpose, fulfilling the wishes of the dying person and being with them so they're not alone. But witnessing the death of a loved one can be emotionally upsetting, and in the short or long term, there is the risk that caregivers' homes become a triage for grief and loss rather than a sanctuary. Despite improvements in palliative care for cancer survivors, barriers exist for sexual minority survivors and their partners or spouses. Healthcare providers report that they've observed instances where care for these individuals or couples was disrespectful and where the care was inadequate or even abusive. In addition, 43% reported instances of discrimination toward the patient's partner or spouse. Older lesbians may be at an increased risk due to vulnerability from isolation and poverty. Barriers to palliative care include homophobia and discrimination, as well as mistrust of healthcare providers. Although the need or ability to participate in sexual activity may wane in the terminal stages of illness, the need for touch and connectedness does not necessarily fade. For those in hospital or another institution, the only touch experience may be from a gloved hand. People may suffer from the absence of loving and intimate touch in the final months, weeks, or days of life. And if healthcare providers don't recognize and deal with this, they're doing their patients a disservice. While talking about the end of life is difficult for many, it's important to acknowledge this final stage of living with cancer. It shouldn't be shrouded in secrecy, nor does it need to be with the end of physical contact. Certainly, the end of life brings with it many unknowns for spouses or partners and other family members. But an important aspect of this stage is that the need for loving touch doesn't go away, even in the final hours and minutes of life. Loving touch doesn't mean sexual touch, but spouses and partners may still need permission to be close to their loved ones at this time. Although some may hesitate, many people find having physical contact with their dying loved ones is a rewarding and special experience. So, I know that is a lot and a very heavy topic, but Ann Katz does such a beautiful job in her writing and also includes a heck of a lot of resources, so I really love this new book. I'm so excited that she wrote it, and I'm so happy that we have access to it. But this particular topic can be really difficult. Even talking about sex and death in itself, or chronic illness, or just the logistics of going through cancer treatment is so overwhelming for many, and that really turns off these 6 inches. But I love this chapter, and that's why I really wanted to read it. The emphasis on touch. Intimacy doesn't have to be stuff going into other stuff, which is my favorite quote from Zach and Mary Make Up More Now. But it is the idea of touch, how we as humans touch each other, particularly at those stages near the end of life, when the only touch that's really going on is super clinical and medicalized. So, question for you. What reactions did you have about anything that popped up in this particular chapter? What do you want to know more about? Had you even thought about sexuality during the dying process? I know it's a lot of heavy in this topic. But we love the heavy, because if we don't talk about this stuff, we're just going to keep shaming it and not talking about it, and that does nothing. So if you liked this video, feel free to like it. If you have questions, put them down in the comments down below, and I will see you next Wednesday for another episode of Psych Reads.